Ulcers and vesiculobullous lesions of the mouth. First is traumatic ulcer, which is the most common ulcer and it is clinically indistinguishable from a malignancy. Then recurrent aphthous stomatitis or canker sore, which is associated with nutritional deficiency, immunocompromised patients, SID, Crohn's disease. It is precipitated by trauma, stress, hormones, seen in women under 40 years of age, non-smokers. It has three types: minor, major, and herpetiform. Minor aphthous ulcer are seen in 80% of the cases on non-keratinized mucosal surfaces, less than 1 centimeter in length, heals in 10 to 14 days with no scarring. Whereas scarring is seen in major aphthous ulcers, these are seen in 15% of the cases, seen on the mucosa overlying the minor salivary glands, and they can last up to weeks and months. Herpetiform ulcers in the 5% of cases, more in women. These are small ulcers which can fuse together to make large ulcers lasting for 10 to 14 days. Then oral ligand planus is T-cell mediated inflammatory response, leads to bone marrow disruption. Most common types are reticular, erosive, and plaque, in which reticular is the type which is not pre-malignant, whereas erosive and plaque are pre-malignant in nature. Other types are atrophic, bullous, and papular. Oral ligand planus is generally bilateral. The reticular OLP is raised with lacework, which is called Wickham's stripe. It is usually asymptomatic, seen on the buccal mucosa and vestibule. Erosive oral lichen planus, it has well demarcated erosions and ulcerations which are covered with pseudomembrane. White striae are seen at the junction of normal and erosive tissue. These are symptomatic, unlike reticular. Plaque is irregular, white, raised, flat plaques, usually seen in the dorsal surface of the tongue. Lichenoid reactions are unilateral, whereas oral lichen planus was bilateral in nature. Otherwise, they are clinically and histologically indistinguishable from the oral lichen planus. These are seen as a result of a reaction to any drug or biomaterial. Oral pemphigoid, seen in patients more than 60 years of age. It is a desquamating condition of all the mucous membranes. It is an autoimmune reaction targeting the hemidesmosomes of the basement membrane cells. Results in subbasilar clefting. Widespread ulcerations throughout the oral mucosa are seen, except the lips. It affects the conjunctival mucosa and can lead to blindness also. Now, pemphigus vulgaris in the patients of 40 to 60 years of age. It is also a desquamating condition of the oral mucosa and skin. It is also an autoimmune reaction affecting the desmosomes of the intermediate cells. It results in the suprabasilar clefting. The target is DSG3 and DSG1, in which DSG3 is attacked more. It affects the lips, unlike the pemphigoid, but mostly affects the torso skin. Nikolsky sign is seen, and key histologic feature are Zank cells and fishnet pattern. Primary herpetic gingival stomatitis. It is the most common viral infection of the oral cavity caused by HSV1 virus, typically seen in children, also occurs in adults. The intraepithelial vesicles rupture easily in this and they leave small shallow ulcers. Symptoms are fever, malaise, and cervical lymphadenopathy. Key feature is erythematous marginal gingivitis. Key histologic feature is degenerating multinucleated edematous epithelial cells. Now, herpangina. Herpangina is not caused by HSV, but it is caused by Coxsackie virus, typically seen in kids, and it is found in the posterior oral cavity and tonsillar pillars. Symptoms are sore throat, fever, malaise, and vomiting.